talk sleep alertness and fatigue education in residency. And so just to let you know that we have quite a few doctors in our division who can see patients with sleep disorders. And so if you on your floor rotations or post-operatively come across patients who have repetitive hypoxemia and return to normal oxygen saturations while sleeping, or they're snoring, feel free to refer them to anybody in our group. So my name is Jigme Sethi, and this is a comprehensive list of my disclosures. I will disclose, however, that I woke up at 3 o'clock last morning to try to catch the Geminid meteor showers. I saw none, but I am sleep deprived. So if you want to keep tabs on the total number of unforced errors I make during this talk, please go ahead and feel free to do so and let me know at the end how I scored. Okay, so I know all the residents and all the physicians want to sleep so that we wake up bushy-eyed and bright and sunny the next morning. Quite honestly, from your purposes, the most important thing to know is that sleep is incredibly important for learning and memory consolidation, and this is how it works. During slow wave sleep, that is deep sleep, the pathways encoded during an awake learning episode are reactivated. So let's say you're learning how to play the piano, your finger movements and your eye to hand coordination, those pathways are reactivated during sleep, slow wave sleep. If you're playing tennis or if you're studying, all the pathways that are activated during that period get reactivated at night during slow wave sleep, and they then get transferred from the hippocampus to the subcortical sites for long-term storage. This is called system consolidation. And once that transfer has occurred, the synapses involved are downscaled so that you can continue the next day to learn new stuff. Otherwise, they'd be saturated, and that would impede new information encoding. And then later that night, during the ensuing REM sleep that occurs, the permanent synaptic buildup is consolidated so that those memories that have been transferred from the hippocampus to neocortical sites are now consolidated and fused in place. So, in other words, you need both slow wave sleep to transfer your newly learned memories to a storage site, and then you need REM sleep to consolidate those that storage, which means that everything that you're trying to learn requires sleep for you to actually be able to learn it and effectively reproduce it the next day. And both the phases of sleep are important. And it turns out that deeper sleep, if you look at the cortical neurons, they reach deeper stages of sleep in those areas of the brain that have been activated by the newly learned task. So the forearm, the parts of the brain that encode the forearm muscles and the arm muscles when you're learning how to play tennis, those are the areas that go into a deeper stage of sleep during the night. And this deep sleep also correlates with improved performance the next morning. And performance, obviously, it stands to reason, is better if adequate sleep has been achieved. So this is how sleep usually works. You start off going to sleep from the awake position, awake state, then light sleep stages 1 and 2 progressively, and then you go into what is stage 3 and 4. They're combined to be called nowadays slow wave sleep. This is an older slide, so I apologize, but stage 3 and 4 is slow wave sleep. Then you progressively lighten your sleep until you go into REM in green. Stay in REM for a short period of time, then go back through stage 2 to stage 3 and 4, slow wave sleep. Then you wake up again progressively, hit REM, you might wake up fully in between, and then you go back down to stage 3. And you notice as you go through the night, 2 things are happening. The REM periods are progressively lengthening. So you're more likely to be dreaming later in the night rather than early. And the slow wave sleep, stage 3 and 4, predominates in the early part of the night, with much less stage 3 to none of stage 3 and 4 in the latter half of the night. Now, same thing seen here, but when you're on call, you can see how fractionated the sleep is. You may hit stage 3 or 4 initially, and then you're woken up completely. You might have a mini arousal here where you're not quite fully awake, and everything gets fractionated, including the REM periods. That's not surprising, but that's what happens. Now, over a lifespan, the amount of slow wave sleep stays relatively constant during middle age, and then it's only in the elderly above 65 that slow wave sleep starts decreasing. REM sleep stays relatively constant throughout the lifespan, and the only change that is dramatic is that waking time after sleep onset, so-called WASO, increases as you get older. But the sleep latency stays about the same. REM and slow wave sleep stays approximately the same. It's really that as you get older, you can't stay in any stage of sleep for any length of time. And the total duration of required sleep stays approximately the same as you achieve adulthood. 8 to 10 hours as a teen, and 7 to 9 hours constant is required as you get older. So for all of you, you need 7 to 9 hours of sleep. Now, what makes us sleepy? Well, process H, or homeostasis, or process S for sleepy, is based upon the use of ATP. Those of you who've rounded with me, I keep asking the question, what is the molecular currency of life? And it turns out, in my mind, the molecular currency of life is ATP, because that powers every cell. And as your brain uses ATP, that ATP is degraded to adenosine. Now, as you stay awake, more and more adenosine accumulates in the brain, and adenosine activates the A1 and the A2A receptors, which switch off dopamine production and make us sleepy. So the longer we stay awake, the more adenosine accumulates. And during early sleep, that adenosine is converted back to ATP, and you're back to being in a brain which has lots of ATP to use. And in other words, you feel bright-eyed and bushy-tailed when you wake up. Okay. Coffee, what does that do? Well, coffee blocks this adenosine receptor, the A2A and the A1 receptor, and therefore dopamine increases and you wake up. The opposite process is process C, which is the circadian process, and the suprachiasmatic nucleus has circadian oscillators, which you all know about, which fire on a 24-hour cycle, and they fire for sleep and they fire for wake, and they're encoded, their oscillators are entrained by two phenomena. One is the release of melatonin. Melatonin is produced in the pineal gland and it makes you sleepy, so it inhibits the circadian clock. On the other hand, the retina, when it's exposed to blue light, bright light, the melanopsin pigment is sensitive to the blue component of light. That signals to the suprachiasmatic nucleus that daytime has started, and it makes you switch to a more awake circadian rhythm, which explains why people who are completely blind basically have no circadian rhythm to speak of. So this is how the two processes work. The homeostatic sleep drive increases as you stay awake, all the way to 11 o'clock when you fall off to sleep, and the adenosine gets converted back to ATP over the course of this period. The circadian drive, which is in green, increases over time to a peak of about just early evening and then starts dropping off, allowing you to fall asleep. So consider this together. You wake up here, and at that time, you've got lots of ATP in your brain and you're relatively bright. And as you stay awake progressively, your drive to fall asleep increases. At the same time as you wake up, your circadian drive to stay awake keeps rising up until about 2 to 4 p.m. in the evening, when actually, if you wish to nap, it's probably the best time to nap because your circadian drive is falling off. The drive to stay awake is falling off a little bit. and you haven't developed so much ATP that you'll sleep, adenosine that you'll sleep all through, you might be able to get away with a half hour or an hour of a nap. Now, what happens if you don't sleep? This keeps rising progressively. Your homeostatic process S keeps rising, and you get to this point, and all through this period, there's no circadian drive to stay awake. In fact, it's trying to make you sleep, and the homeostatic drive is trying to make you sleep. And then when you wake up and you proceed to rounds around 8 o'clock in the morning, you can see that you are very likely to fall asleep, and the circadian rhythm, circadian process C has not quite peaked, it's just begun to be active. So there's really nothing keeping you awake during rounds, and you tend to fall off to sleep until your attending questions you. Okay, so Alva Edison invented the light bulb, and we stopped sleeping at night when it got dark. And this man, to quote him, he said, "I never needed more than 4 or 5 hours sleep in 24. I never dream, and my sleep is really good and refreshing." And yet every picture of him that we have in posterity shows him sleeping. And you can see that even in his library and in his office, he had a bed. Well, 83 years after that, I don't know if you can see this, but the LED was invented by Nick Holonyak, and the LED allows us now to stay in bed at night with the lights off and yet glued to our phones, and again, not sleep. So onto the substance of the talk. You've heard a lot about sleep. Now let's talk about how it affects you in your career. I'm going to list the risk factors for sleepiness, try to get you to recognize sleepiness, describe the impact on you when you stay awake through night call, and challenge some of the myths and misconceptions that most of us have about being able to function when sleep deprived. And finally, we talk about some programmatic goals to try to keep you awake and good at learning. So all of us in medicine get insufficient sleep. But when you're on call, or if you're at home taking call, your pager goes off, you get phone calls. So even the very sleep you get is fragmented and not good quality. And then as we switch from day to night calls, the circadian rhythm gets disrupted. And a few of us may have primary sleep disorders. And so there's no surprise that all of these put together give rise to excessive daytime sleepiness. And so it's not surprising to note that residents report, sleepiness that is on par with patients who have narcolepsy, and more sleepiness than those who have sleep apnea, because of what I just described in the last slide. There are some specialties that are more prone to sleep deprivation. Neurosurgery tops the list out of these 5 selections. And this is based on a score of, I'm usually sleep deprived from 1 to 5. 5 is almost daily, and you can see neurosurgery scores up there. But this is a list of all the other specialties. And just to outline a few, internal medicine, 68% of respondents felt that they slept 6 or fewer hours per night, or rather, no, 68% of their nights were 6 or fewer hours in terms of the amount of sleep they got. And general surgery, 94% of their nights were 6 or fewer hours per night, whereas neurosurgery was even higher at 94.4. So you probably fall in between these two extremes. Anesthesia, much less. Dermatology, 31% had nights that were 6 or fewer hours in duration. So this is the common myth that we as physicians don't need sleep. We're better and more dedicated doctors if we can do without sleep. And I like to boast that I've just come off a 10-day, 12-hour shift cycle. And so I've worked 120 hours in the last 10 days, but actually maybe I did compromise patient care, and I certainly didn't contribute to your education. So that's a myth. And as you can see, we all need the same amount of sleep time. And so this myth look, like a lot of residents, I only need 5 hours of sleep, so none of this applies to me. Well, the party lying the safer directive is to tell you that that's a myth, that sleep loss is cumulative. Getting less than 8 hours of sleep starts to create a sleep debt, which has to be paid off, and working memory lapses become evident when we're limited to 6 hours of sleep per night. Now, the truth of the matter is somewhere in between and a little more nuanced. It turns out that we may all need 7 to 9 hours of sleep, but some of us are less vulnerable than others to sleep deprivation, because sleep deprivation may be heritable. And this is a study in twins that shows sleep deprivation, the impairment, the behavioral and psychomotor impairment produced by sleep deprivation is actually highly heritable. And in mice as well, they've been able to breed mice to show the same thing, that the area on chromosome 13 in mice actually encodes for a resistance to sleepiness. So even though they may need the same amount of sleep, both mice and humans may actually vary in how they react to sleep deprivation. Sleep deprivation does not impact all people equally. Some individuals show cognitive resilience to the effect of sleep loss, whereas others show vulnerability. And in this particular study, they checked to see what the learning ability of subjects was after 8 hours of sleep. Then they were deprived of sleep and checked again. And finally, they were allowed to nap for 90 minutes to see how they performed on learning tests after a recovery period of napping. And I'll show you what it shows. It turns out that there is this purple part of the hippocampus, the CA3DG part of the hippocampus, and the volume of this hippocampus correlates with the lack of susceptibility to sleep deprivation. In other words, better functioning during sleep deprivation. So here you can see the change in learning with sleep deprivation was higher. The change in learning was worse. There's a negative slope with the larger hippocampus region, CAD3, but it did not affect, the size of this did not affect the recovery from sleep deprivation and the learning impairment, which is shown in blue. So the larger the hippocampus, the less the deprivation of learning. But on the other hand, the recovery was not encoded by the size of the hippocampus. What was encoded was the amount of slow wave sleep. So if you got a lot of slow wave sleep, the recovery was dramatically improved in terms of the learning disabilities that occurred. So there's a part of the brain that correlates with the ability, and that is heritable, and that correlates with the heritable trait that some people are less sensitive to sleep deprivation in terms of their performance on psychomotor tasks. But the recovery in all of them depends on the amount of slow wave sleep during the napping that they took. And you'll notice from that previous graph that the nap period was 90 minutes, by which time slow wave sleep would normally have been achieved. Okay, so I've learned not to need as much sleep during my residency. That's clearly a myth. Learning may actually reduce errors, but optimal consistent performance worsens with sleep debt. So you cannot over time learn to do without sleep. This is a very important slide, and I'd ask for your patience as I walk you through it. This is sleepiness score on the y-axis, and on the x-axis, these are subjects in triangles who slept for 8 hours. So you can see they don't score high on the sleepiness score. In squares are subjects who slept for less than 8 hours, in other words, 6 hours. They're more sleepy subjectively than those who slept for 8. And in circles are those who slept for a period of no more than 4 hours. Now, this is over 14 days. So notice a couple of things. Over 14 days of sleeping 6 hours or 4 hours, there's a gradual increase in sleepiness. It's not profound difference between here after the first 2 or 4 nights of sleep deprivation and 14 nights, but there's a mild increase over time. Most of the change occurs early on. In black are subjects who were made to go without sleep for 1 day, 2 days, and 3 consecutive days. So in other words, they stayed awake completely for 72 hours with no time in bed. You can see how dramatically their sleep deprivation, how their sleepiness scores increase over time. Now, this figure here, this panel here shows the PVT, the psychomotor vigilance testing lapses. You can see that in those who slept 8 hours each night, there's a slight increase over time of their performance, their lapses on psychomotor testing. But look at these guys who slept in squares, which is 6 hours, and those who slept only 4 hours over time. There is a continual increase in poor performance as measured by lapses, such that after approximately a week or 5 days of being sleep deprived, they were on par with folks who had not slept at all for 1 night or 2 nights. And this was progressive over time. So, as you can see, as the cumulative sleep debt increases, the number of lapses increases. However, when you've stayed awake for 1, 2, or 3 nights in a row, the performance is significantly degraded. But look at it another way, and that's what I find to be really intriguing about this particular study. In this part here, the sleep debt is 8 hours here, 16 hours, and 24 hours in folks who've been completely sleep deprived for 3 consecutive days. And sure, there's a complete difference in the nature of this PVT lapses there as compared to those who were progressively deprived of sleep. But here, they actually plotted the same data based upon cumulative excess wakefulness. So if you were awake for longer than 16 hours, then the amount of PVT lapses increased. In other words, for folks who had not slept for 1 day, 2 days, or 3 days, it's actually not so much the sleep debt, but the amount of time you're continuously staying awake while the adenosine is increasing in your brain that really matters in terms of how you perform on PVT testing. So if I'm completely if I have no sleep debt, and I stay awake, and I stay awake for longer than 16 hours, and then go on to 24 hours. It's the period of excess wakefulness that makes for the errors. And if I was sleep deprived and I come into a prolonged period of wakefulness, again, it's the wakefulness period that correlates more than the sleep debt with the degree of impairment that I would experience. So I'll phrase it differently. 14 days of 6 hours of sleep per night gives you a sleep deprivation kind of state of 2 nights of total sleep deprivation. Or 1 week of sleeping 5 hours per night gives you the same state as being awake for 24 hours. And if you're awake for more than 16 hours at a time, that's when performance lapses start occurring. So, how do we recognize sleepiness? Now, obviously, there are grades of sleepiness, right? And we all think, I can tell how tired I am, and I know when I'm not functioning up to par. That's not true. That's BS. The sleepier you are, the less accurate your perception of the degree of impairment, very like when you're drinking. And there's a phenomenon called microsleeps that I'll talk about as well. So notice this. These were, back to the same graph, these were people who were sleep deprived progressively over 14 days. And you can see their own judgment of their sleepiness did not change dramatically, maybe half a point on the Stanford sleepiness scale over the period of the 14 days that they were progressively sleep deprived. But what happened to their performance? Rapidly degraded out of proportion to their individual perception of their sleep deprivation. So if you think you're functioning fine while you're sleep deprived, it's akin to thinking, I'm drunk, I can drive, I'm competent, while you're not. And this is a study in residents. In residents who were asked to have EEGs done and a sleep study done when they were working a baseline normal work schedule. And then they had sleep studies done after a 24-hour on-call period and then following a period of recovery sleep. And it turns out these residents were unable to identify nearly 50% of their sleep episodes, which were determined by EEG. In other words, of course, they were sleepier after being sleep deprived, but in 50% of the cases, they didn't even know when they fell asleep on the MSLT. Microsleeps. These are unintended sleeps of about 15 seconds in duration, sometimes 30 seconds in duration. And how do you recognize it? Nodding off to sleep like I am, drooping eyelids, and slow rolling movements of the eyeballs. And if you were having these microsleeps, you might be able to identify this as a spacing out in which you don't remember what exactly happened in the preceding few seconds. So in this study, all the interns who participated in the study wore helmets. These helmets had cameras that allowed the researchers to detect slow rolling eye movements, which indicate stage 1 sleep. And they studied them on rounds while they were working during their normal schedule. And then they intervened and gave them the usual schedules that you folks are used to now, which is a longer period of sleep and shorter time at work. And as you can see, the number of microsleeps dropped off dramatically once they got more sleep. This is both as a group, and these are each individual. There's some of them that went up, and we don't know whether they were sleep deprived or not, but the majority of them, the number of attentional failures or microsleeps where they had slow rolling eye movements and actually fell asleep while standing up on rounds, reduced after they were less sleep deprived. So these microsleeps happen, and all of you have experienced it, and some of you, while listening to me now, may be actually going through the same motions. So how do we recognize sleep? Falling asleep while I'm talking to you, being restless and irritable with staff, colleagues, family, and friends, having to go over your work and forgetting that your note was not complete and having to go back to it to make corrections, having difficulty focusing on the patients, and finally, just feeling like you just don't care. These are all signs of sleep and deprivation and the stress that goes along with it. And so what happens when you're sleep deprived? Of course, you can crash your car. But there are effects on learning, there's effects on health and well-being. There are multiple other domains, family relationships, mood and performance, and of course, of importance to us, there's patient care and professionalism. So I'll try to go through the domains one by one. As nightly sleep increases, the ability, this is residents reporting this, the ability to learn improves, the learning ability increases in green. The stress rating goes down among residents. The feeling of being humiliated on rounds goes down. So I'm willing to posit that if I pimp you for questions on rounds, you're probably going to respond negatively based upon the amount of sleep you've had in the preceding night. So I will try to stay away from the residents who are post-call and direct my questions to those who slept at night. But you can see that just the feeling of self-impairment goes down as residents get more sleep. But this is not new. In 1971, this was described. Mood was significantly affected among interns by sleep loss. Deprived interns felt increased sadness, decreased vigor, decreased egotism, and social affection. Numerous psychopathologic symptoms developed, and they judged themselves to have abnormalities, cognitive, perceptual, but also physiological areas of function. And it's postulated that, not postulated, it's shown that interns deprived of normal sleep may experience transient psychopathology and impaired efficacy of performance. So I get the impaired efficacy of performance, but psychopathology? Here's what happens. Your own patients have become the enemy because they are the one thing that stands between you and a few hours of sleep. And take a look at this. Residents averaging less than 5 hours of sleep per night were significantly more likely to report involvement in a malpractice lawsuit with an odds ratio of 2. Conflict with other residents, odds ratio 1.86. Serious medical error, 1.74. Conflict with nursing staff, 1.5. Increased use of alcohol. So professionally, you perform worse when you don't sleep, or when you are persistently sleep deprived. It's not just learning. What about performance and patient safety? After 17 or 19 hours without sleep, performance on some of the psychomotor vigilance testing was equivalent or worse than that of having a blood alcohol level of 0.05. And after longer periods than that, it came up to the equivalence of a blood alcohol level of 0.1%. So it's like working drunk. Now, residents self-report errors, of course, depending on their level of sleep. Those who sleep more have lower self-reported errors and lower adverse events. Serious medication errors are also reduced when residents sleep well. And by the way, there's 5 times as many serious diagnostic errors in residents who work the Q3R 30-hour shift, Q3-day 24-hour shifts versus those who have an intervention schedule. 5 times as many diagnostic errors. And you can see the difference in performance between sleep deprived and non-sleep deprived subjects. 20% more errors among surgical errors, 14% more time to perform simulated laparoscopy post-call. EEG interpretations tend to, when used as a test of performance, are significantly worse in sleep-deprived interns. Pediatrics, there have been studies that the time required to place an intra-arterial line increases significantly in sleep-deprived residents. Same thing with history and physical and emergency medicine. Family medicine scores on the training exam correlate with the pre-test sleep amounts. It's pretty standard stuff. What about the impact of personal health and safety? Among pregnant residents, there's a 12-fold increased risk of premature labor, not premature delivery because they usually get out, but 12-fold increased risk of premature labor. Depression increases from 4 to 30% over 1 year of sleep deprivation, and up to 3/4 of residents report burnout symptoms. I found this quite interesting. This is from the MMWR in 2014. Short sleep duration is associated with greater likelihood of obesity, hypertension, diabetes, coronary artery, stroke, and death. That I'm going to show you. But what I found interesting is that in the Southeast United States and in the Appalachian Mountains, the area where we are, the prevalence of poor sleep is much higher than the rest of the continental United States, probably explaining the obesity as well. So sleep debt can cause weight gain, quite a bit of weight gain. How? Sleep loss decreases leptin, and leptin is a suppressor of your appetite. On the other hand, sleep loss increases ghrelin, and ghrelin makes you hungry. So this is from, I doubt you can read this, but these are all the different studies that have used different degrees of sleep deprivation, and they've all shown that the energy intake per person was increased relative to baseline from values varying from 511 kilocalories per day to 221 kilocalories per day. This study, 6%, 182 kilocalories per day. Energy intake was increased by 559 kilocalories per day. So there is a fairly dramatic, up to 25% increase in the amount of energy intake when you're sleep deprived. And the American Heart Association states that short sleep, less than 7 hours, is associated with incident diabetes, hypertension, coronary artery disease, and stroke. And it turns out in a study of nearly 500,000 UK participants who were free of coronary artery disease, who were ages 40 to 70 and followed up for 7 years, short sleepers who had less than 6 hours of sleep, their incidence of incident MI, in other words, coronary artery disease and myocardial infarction, in those 7 years of follow-up after being free of coronary artery disease at baseline, was increased by 20%. And if they were long sleepers, which is the other end of the J-shaped curve, the risk of incident MI was increased by 34%. But of importance to you, less than 6 hours of sleep is associated with a 20% increased risk of incident MI. And we talked about micro sleeps, and we said they can go up for about 4 to 15 seconds. Well, think about this. You're driving home post-core. You have those micro sleeps that you saw so commonly in those residents who were studied in the NEJM article with the helmet, with the cameras looking at slow rolling movements of the eyeball. Those micro sleeps, falling asleep on rounds. A car driving at 60 miles per hour will travel more than 250 feet clear across an intersection during a 3-second micro sleep. So it's not surprising that for each extended duration work shift, that means more than your 8-hour shift, per month, interns had 8.8% increased monthly risk of a motor vehicle accident for every extended duration work shift per month. So if you had 2 extended duration work shifts, the incidence went up by 17%. And here, increased monthly risk of a motor vehicle crash on the commute home from work for each shift was 16% higher risk. And this is based on a large population, nearly 3,000 residents in 14, 17 person years. We know that when daylight savings time comes on and goes off, there are increased road traffic accidents because of 1 hour less of sleep on the night prior. So the Monday in spring, when you lose an hour of sleep, the Monday before that daylight savings time change, there are this many accidents. But the Monday after the Sunday night change, because 1 hour of sleep has been cut short, the number of accidents goes up dramatically. And the opposite occurs when you get an extra hour of sleep in the fall. So in New Jersey, driving after having been without sleep for a period in excess of 24 consecutive hours is now explicitly considered reckless. And there are profile cases, the high profile cases in courts where the hospitals have been responsible for fatigue-related crashes after the staff have left work. I don't know of any law that has been passed, but maybe there are some that are pending, which makes drowsy driving a felony. So this affects you. And you can recognize it because you are driving when you know you're sleep deprived. You're having trouble focusing on the road, keeping eyes open, nodding off to sleep, yawning, drifting from lanes, not remembering driving the last few miles, those micro sleeps, and closing your eyes at stoplights. So what works? Only two things. Avoid driving if drowsy, use GME paid Uber or a taxi drive home. And I strongly suggest this. Yes, you can pull off the road at a safe place and take a short nap, but most of you work fairly close to your homes. So maybe that's not relevant. You could take a 20-minute nap before you set out to drive or drink a cup of coffee. But remember, coffee takes 30 minutes to kick in. So don't drive immediately after drinking your coffee. It won't be beneficial. Most often try to use this. Trying to use cold air, opening up the window, turning up the radio, none of that works. So coffee. It reduces sleep deficits, sleep-related deficit at this dose, 75 to 150 milligrams. But the important thing is to remember it takes 30 minutes to kick in. And its half-life can be up to 7 hours, which means if you drink it in the morning, you might have trouble going to sleep at night. 3 sevens are 21, 3 half-lives, it's still around to some degree or the other when you go to bed in the evening. So use it strategically. And of course, it's a diuretic, so it may wake you up during you may wake up during your nap. And usually most of the ways in which we drink coffee provides that 75 to 150 milligram that has an alerting example. But if you want to know, pour over coffee is the most potent. So how else can we accommodate to sleep deprivation? Well, aviators use modafinil, and modafinil was used during Gulf War I when the stealth bombers took off from Missouri, flew all the way to Iraq, bombed Iraq, encountered enemy fire, and flew all the way back and landed in Missouri. How did they do that? Single pilot using modafinil. So that's one drug that has been shown to help with battling fatigue. Or you could turn out to be a dolphin. Dolphins can continuously echolocate and accurately report the presence of targets for at least 15 days continuously without interruption. Now, how do they do that? Because they sleep one hemisphere at a time. They switch off one hemisphere. All fish do this. They switch off one hemisphere, that gets sleep. The other hemisphere is being used to determine where they are. Natural currents in the ocean causing them to drift. And then they switch and the other hemisphere goes off to sleep, something I'd love to evolve to be able to do. But for now, it's modafinil. So what can we do? What else can we do to reduce the impact of sleep loss? Avoid starting out with the sleep deficit. And it turns out that most residents sleep an average of 6.38 hours per night, even when they're not on call and not working clinically in long hospital rotations, but are in clinic or research electives, etc. So obviously that's something to avoid. Avoid starting out with the sleep deficit. Protect your sleep time. You've got to get the kids and the family members to recognize that when you need your sleep, you need your sleep. So go try to keep a healthy sleep-wake cycle, develop a routine, but most importantly, try to get protected sleep. It helps to sleep in cooler environments, to have to be quiet, of course, and have dark eye shades or room darkening shades. Avoid going to bed hungry. No heavy meals within 3 hours of sleep. Avoid alcohol. It induces sleep onset, but disrupts sleep later on. Think of it as a mini DTs. You have a bit too much to drink, you fall asleep immediately. And then after about 4 hours, when the alcohol has been metabolized, your brain goes into actual mini DTs, even if you're not an alcoholic, and you wake up and you can't go back to sleep. What about napping? Take short naps no longer than 30 minutes to avoid sleep inertia, and take advantage of the windows of 2 to 4 a.m. and 2 to 4 p.m. Now, what is sleep inertia? When you wake up after a longer nap that is a little longer than 30 minutes, but not long enough to pay off all your sleep debt, you wake up into a kind of fugue state where you just can't stay awake even though you've woken up, and you kind of feel foggy. Why does that happen? It usually happens when you emerge straight from slow wave sleep, and that's why if you get into slow wave sleep by about 1 hour. So if you sleep less than you sleep about or nap for about 30 minutes, you won't enter slow wave sleep, and you'll wake up feeling refreshed without sleep apnea. And like I showed you, this part here, 2 to 4 p.m. in the afternoon, your circadian drive to stay awake is falling off, and you kind of getting sleepy because you used up some ATP and created adenosine in your brain. That's the time you'll be able to fall asleep, 2 to 4 p.m. And then 2 to 4 a.m. is the period when you're very likely to fall asleep because your adenosine has increased dramatically, but your sleep drive, your wake process C is not active. So that's the time to fall asleep. If you fall asleep closer to 7 a.m. after you've got your night's work done and just before rounds, your circadian rhythm will start disrupting the ability to fall asleep. So I used to get used to night shifts right away. I can switch without a problem. That's not true. It takes a week. So all you have to do is pretend as you prepare to go on night shift to kind of move your sleep time later and later from 8 p.m., 9, 10, 11, and wake up a little later, and then finally go to sleep, stay awake on the night that you are going to go into night shift, and go to sleep from 9 a.m. to 4 p.m. before you go on to night shift. So try to mimic as far as possible a slow change towards being able to stay awake at night. So nap before work. Have as much exposure to bright light in the hospital when you need to be awake. When you go home and sleep, wear dark glasses on the way drive home so that you're not going to be alerted by the Zeitgeibers or the blue light circadian disruption. So what can we do as a program? Truckers are allowed only to drive for 11 hours, not the 36 and 24 hours you guys have to work. Pilots, maximum 8 hours per 24-hour flying domestic routes. Nuclear power plant workers, 12 hours. Train engineers, 12 hours. Only physicians work this long, but not everywhere. In Europe, there's a law which applies to practicing physicians as well as residents. Maximum of 48 to 56 hours per week and no more than 13 consecutive hours. So what I did last week, work 120 hours, 84 hours, would be outlawed in Europe. And in New Zealand, maximum of 72 hours weekly and no more than 16 consecutive hours. You know, today I'm dying to move to Europe. Okay, so we came up with these duty guidelines. 80-hour work week, PGY1 cannot work more than 16 hours. Expanded requirements for handoffs to make sure that there are no errors. Stricter requirements for supervision of PGY1. And then, as they said, competence is about learning how to do something right, not learning how to do it a multiple number of times. And so use simulators, let the high-risk procedures, central lines, arc lines be done by the incoming team. Schedule, videotape all these conferences so you can listen to these conferences after you've had a good night's sleep. All of this came about But the most important and fundamental factor is not to start out with a sleep deficit. So how did all this work? Well, it turns out focusing on duty hours alone, this is a systematic review, has not resulted in improvements in patient care or resident well-being. In fact, the added duty hour restrictions appear to have had a negative impact on resident education. Why would that be so? So it turns out the residents may be better rested, but they're more stressed because of work compression. They get less time at work, but the work that is required to be done stays the same. And now they're compressing a lot of work into a short period of time. Discharges, discharge summary dictation, getting new admissions. And as a result, they may be better rested when they come to work, but they're more stressed by the time they leave work. And in terms of resident duty hour restrictions and patient mortality, multiple studies, no real difference. So something else is needed. So in 2017, the duty hour standards changed a little bit. They created a culture of support. You're supposed to be able to talk to your supervisors and your program director and to me to say that this doesn't work for you. This particular schedule doesn't work for you, and we're supposed to support you. And this slide is very interesting. So they took residents, these are all surgeons. They all wore an actigraph, which is a wristband similar to the iPhone, to your different types of sleep monitoring devices that you can put on your wrist. And when there's less vibration, it's assumed you're sleeping. When you're up and walking and moving around, there'll be vibration, that's assumed daytime. And so by actigraphy, they were able to judge when a resident, a surgeon, was awake or asleep. And this is a representative surgeon who shifted to a nighttime schedule from a daytime schedule, such that the residents started working and staying awake at night and sleeping during the day. And you can see by Thursday, Friday, Saturday, the third day, their performance was in the red, which is high fatigue risk, high risk for accidents. And then it got a little better once they adapted to that new circadian rhythm. But you can see progressively as they went through the circadian rhythm, they were awake during the night, asleep during the day, and gradually by the midweek, by 1 week, much of their time spent awake at night was in this red zone where their errors were much more frequent. And that is why it's important to recognize that we all get sleep deprived. When we shift schedules, we have the circadian rhythm disruption and we perform poorly. And so it behooves both the residents and their supervisors and the attendings and the program director to look into this aspect and have a shared culture of well-being to try to make sure that we don't commit adverse errors, don't contribute to patient poorer outcomes for the patients by being at least cognizant of the fact that we're sleep deprived. But the elephant in the room really, in this case, the sleeping elephant, is this: we still are part of the same culture. We still believe, physicians, sleep is optional. Less sleep makes you a more dedicated doctor. And that is wrong. So this was the statement by the American College of Surgeons that was reapproved and reissued in 2002. Patients have a right to expect a healthy, alert, responsible, and responsive physician. I'd like to make a similar statement that providers have the right to experience a healthy, alert, well-rested, and highly functional lifestyle. I'm not sure there's a resolution that I can provide you in a short period of time to tell you which way this will work out over the next few years, but clearly there's a pressure now, and an expectation that we will all combine together to create a culture of safety. And that includes a culture where we can, as providers, have a healthy, alert, well-rested, and highly functional lifestyle. Questions before you fall asleep for good? I'm sorry, if anybody has questions, you can either unmute yourself and speak. Otherwise, I'll assume everybody's asleep and using this nice opportunity to nap. Thank you.
Thank you so much, Dr. Sethi. We appreciate your presentation.
Not at all. Thanks.